that's not so great to deal with either.
The maximum you do is a biopsy. So welcome to the next episode of Endoscopy Essentials, again with a fantastic Doug Rex. Doug, welcome again.
Thank you, Thomas. Thanks for having me.
Doug, you had a recent paper about polyp recurrences and how to treat them. Let's start with the advice. If somebody who is not so experienced sees a large polyp, whatever that is, or a difficult polyp, there is this tendency to try how far you get. But isn't that making the life of the next guy much more difficult?
Yes, it does make it more difficult. And something we need to get a handle on is like how much of that goes on, because sometimes people try and they probably are successful. We actually, in my practice, we see a thing which I don't discourage, where somebody will take out a polyp and they're not totally sure if they got it, and they'll ask me to do the follow-up in 6 months. And sometimes they go in there and they got the whole thing, but they're just not quite at the place yet where they feel always confident in the resection or in doing the follow-up, because at follow-up, if there is recurrence, there's going to be some fibrosis that has to be dealt with. But I think as a general rule, especially from our perspective, because that we tend to take this from as the doctor who's getting the referrals, and they have out there in the community, they have a different perspective. They may have weird sort of restrictions on referrals. They may have patients telling them, I just can't travel to Hamburg or Berlin. It's too far away. In the States, we see a lot of that. People from small communities that just don't want to travel. We have hospitals that are like putting pressure on people to keep the care there because they want the income from it. And that maybe is a kind of a uniquely American problem, but it's a problem.
No, it's not.
It's not. It happens elsewhere too. There are different sorts of pressures that are on people. Ideally, from our perspective, yes, we would like for people to certainly not resect part of the polyp. Unfortunately, I see people sometimes take snare biopsies. They think they're like helping us by taking a chunk off with a snare, which never makes sense. And for really flat lesions, we would prefer not even to have biopsies. I do like to have a number of photographs, and we get the photographs every time, and we look at them right shortly after the referral to help us triage the lesion. Because sometimes we can tell it's something that can wait 3 or 4 months, and other times I say, we need to take care of this in the next several weeks. This is a higher risk lesion. And if a tattoo is placed,
that's been my next question.
Yeah, you really want to get away from the lesion, because the tattoos, you can put a 1 ml of tattoo in, and the thing will spread sometimes over a 5 or 6 centimeter area, and then get under the lesion, and that can create a bit of fibrosis. I think it's more trouble for ESD than it is for EMR. I don't really have that much trouble with it with EMR, but there have been reports of perforations during EMR, and the layers seem to be stuck together. The tattoo went into the muscle as well as the submucosa, and the layers get stuck together, and so there's some risk to it.
I think it should be greatly discouraged, because if you want to make resection really difficult, you put a lot of tattoo underneath.
Yeah.
So if you tattoo, then stay away. That's a very important message.
Yeah.
Number one. And number two, I think it requires, as a specialist center, a lot of diplomacy to deal with your referring physicians and convincing them not to do something, while starting from personal ambition to structural, requirements. This might be difficult, but the best would be not, right? So
yes,
describe the polyp where it is. The other thing is good photographs, which is not so frequent.
Right. Yeah.
Any tips for that? What to do, or rather a movie nowadays, or?
You need to you need to get good ones. You need to hopefully see the entire lesion, so that, because the size is often underestimated or overestimated, and you get a better sense about the size if you get the entire lesion, get it in focus, of course, transmit it in color. We see people will fax us the report, and it's in black and white.
Black and white. Artistically interesting, but
yeah. Yeah. So the photographs are very important, and we actually rate the photographs as just part of our data collection, and we say that the photographs are really high quality about half the time. Mm-hmm. So I think there are a lot of times, yes, when people could do better because we do rely on those.
Right. And the other question which came up from what you said, when would you continue? Because if there is a polyp, it's probably not fully taken out or surely not fully taken out. So do you do it during the follow-up in whatever 6 months, or should they be sent soon, ideally, if you had enough space, etc.?
Well, yeah, I think it depends on the decision that the referring doctor is making. I think if the referring doctor is confident that they've stopped short of a complete resection, that lesion should be referred. And they shouldn't try. If you couldn't get it the first time, because we want to get everything in its entirety the first time. If you couldn't get it the first time, you should not try it again. You should refer it. Mm. It's probably better to refer it somewhat sooner. The University of Chicago, had a recent study where they showed that the longer the period of time between that initial attempt and when the second attempt occurred, the greater the amount of fibrosis. So fibrosis apparently takes some time to develop. On the other hand, if there's, when you get in there to do the resection, if there's still a lot of ulceration from the first resection, that's not so great to deal with either. But probably the right thing is if you know you couldn't get it, it's better to just go ahead and make the referral at that time.
And the ideal interval would be what, 4 weeks or? Minus, of course, as usual, but
yeah. I think that's probably a good number. I don't know for certain what that number is based on what we know right now. All I can say is the longer you wait after a partially resected lesion, the fibrosis probably getting worse over time.
Okay, Doc. So you brought some very nice cases. Let's go through them step by step and have the questions on the case.
Okay, that sounds great. So I guess I would say by background that when we're talking about recurrences and partially resected polyps, that it's an area where I can't think of really any controlled data. What you have is a lot of observational stuff, and you get a lot of opinions about it too. So there's a school of thought among the ESD people that they think recurrences are best, or partially resected polyps are often best managed by ESD. I know I've seen papers out of Europe about managing it with the full thickness resection device.
Yeah, that's the other school.
Yeah, that's another school, right? And so my opinion and my approach in general, and the result of our recent paper, is that we can manage pretty much all of them with conventional resection techniques. And so that's kind of what I'm going to demonstrate here.
Which you are in line with Michael Berg, who had a paper in GUT, by the way.
He did, exactly.
And there will be a randomized study coming from Germany comparing the full thickness with conventional techniques. It's not yet finished, but then we will have an answer.
Yes.
Whether that's really better.
And I'm sure that in many instances, the full thickness device is fantastic for finishing the situation. It has a very low recurrence rate, but it also, has it. I mean, as you know, it has its own set of issues in terms of the perforation rate, at least in the literature, is higher than it is with conventional techniques. Sometimes, the sigmoid's bad. You can't get up to the site. It's et cetera. So, okay. So this first case is really a follow-up of an EMR in the right colon, and we're looking at these bumps. And the point here is just to make it's critical for people who are doing follow-ups, especially after closure with clips, to be able to recognize artifacts that occurred from the clip.
So this is not adenoma, that's the message?
It's not adenoma.
These are clip bumps.
Yes. And my experience with fellows is that the first couple of times they see, clip artifact and clip bumps, they think, oh, that's recurrent polyp. And, if we look at the site with narrowband imaging and with maybe a little bit of magnification, we can immediately see that the pip pattern on these bumps is is normal and it's not recurrence. And it's important, I think, to recognize that. Now, sometimes if I know that the subsequent follow-ups are going to be done by the local physician, I actually will biopsy this just to get it off. Because if you biopsy it, then with the subsequent follow-ups, it's much less prominent and less likely to be confusing. But
cold snaring?
You can either use a cold forceps or a cold snare. I usually will not take the clips off. But if you in the very, very rare instance, with my own resections, I virtually never see this, but occasionally I'll see somebody partially resect a polyp, put a clip on the defect right over the area where the polyp was. And then when the patient comes in, there'll be clip on polyp. And you do, of course, need to remove those clips before you do the resection. But when the clip is just on clip artifact.
Like this big one, is how can you be sure that there is no little adenoma remnants or no little adenoma remnants underneath?
I think basically that you just rely.
The small one's okay, but the bigger one?
Yeah, I think basically you just rely on your pit analysis. When the clip is still on, the pits are more likely, the tissue is a little bit more inflamed, and the pits are still round, but they're oftentimes a little bit bigger and a little bit darker. I also, just in general, I just almost never see it. So I don't necessarily remove attached clips at follow-up when I'm confident that there's no residual polyp.
That's a very important message. So the message is the maximum you do is a biopsy if you are not 100% sure, but only 95%.
Right.
But you should not do aggressively remove the polyp, cold snare everything, and then say, now I'm 110% sure.
No, I don't think so. I think you look at the site, you make a decision. Are there pits that are consistent with the previous polyp histology, either adenomatous appearing pits or serrated pits if it was a serrated lesion? If you see those, yes, you treat those. But if you see clip bumps, as you said, I like that term, we call it clip artifact, you can biopsy that. As you know, a lot of papers are emerging, and Michael Burke is, sort of feels like biopsy in general, if your assessment is there's no residual polyp, is a waste of time and money. And I've sort of come to that in my own practice, but we do occasionally see positive biopsies, and those people who have positive biopsies, in our experience, they are more likely to have a late recurrence. So I think in some situations where people lack confidence, then it's probably okay to take some biopsies. And if you did get adenoma, we usually will still wait a while, because you want to wait until so there's time for something to grow up into a discrete lesion that you can target with your therapy. But a patient who had a positive biopsy can really be strongly encouraged to come back for that follow-up.
Yes. So that would also favor a slightly longer follow-up than 6 months even. That you say, let everything settle down and you will be able to manage it anyway, irrespective of whether it's at 6 or 12 months, right?
Yes. Well, you may be aware that we published a study maybe in the past year in GIE looking at 12-month follow-up, and we didn't have any real negative consequences from that. And the rules that I would use right now, if I were going to come up with sensible rules for when a 12-month follow-up is appropriate, one would be first of all, you've done a pretty good job of clearing the rest of the colon, because there's a lot of synchronous disease. So you want to have made sure that the patient doesn't have another cancer in there. Because we actually, about 1 in every 200 referrals, we will find a cancer that is not in the lesion the patient was referred for. But so you want to have cleared the colon pretty well. And then secondly, SSLs. I think SSLs are very slow growing, and individual SSLs don't have the same risk as adenomas. So we will consistently wait a year in that setting. And then if the lesion is kind of under 40 millimeters, the recurrence rate is lower. And high-grade dysplasia.
Absence of high-grade.
Yeah, which is a little bit tricky, but we have had, in the course of like 7,000 polyps, we have had a handful, about 4, that when we came back for the first follow-up, we had cancer growing on the site. all of them had high-grade dysplasia on the initial pathology. So for high-grade, we typically will prefer 6 months for that lesion.
Okay, so a lot of questions on the occasion of simple bumps, but let's go on.
Okay, so this is another follow-up of an EMR. This one in the right colon. We've got the near focus, and it just make the importance of looking with some kind of electronic chromoendoscopy and also with magnification, and you can see that there is a flat recurrence here, which is pretty subtle. It wasn't initially obvious. Often very flat. These pits out here, can you see my mouse okay? Yeah, these are normal pits, and these are normal pits out here. It's this area right here that I'm outlining. That's recurrent adenoma. Yeah, just exactly in the middle. So here we have, a recurrence that is sitting on top of a scar, and the question is, how should we remove this? We'd have the options of cold snare, hot snare. We could try to inject it. We could remove it by avulsion. And here again, we could, some people, I don't know if people would actually do full thickness resection for this, but it is a recurrence. And and again, I don't think we have controlled data, but in our experience,
but the gut feeling would be avulsion is too little and full thickness is too much.
That would be my feeling, exactly. I'm going to agree with you. So we typically will just take a snare. I usually, I don't always inject if the...
Doesn't it make the extent clearer if you inject blue?
It can do that, but sometimes you're more likely to get an intramucosal injection. It depends from my standpoint. If it's right in the middle of the scar, I think, it doesn't lift well. One thing I do think that happens is that it'll still, even if it's not lifting, it'll sort of go into the submucosa, and you can see the submucosa well. But I think many times, just if it's right in the middle of the scar, everything's scarred down, just getting a snare of appropriate size and deflating a bit. So, because when the scar is there, the snare has more of a tendency to slide across the scar, and so that you get a good grip. And then we usually burn up the margin, and then I usually close these with clips. And again, this is an area where there's again no evidence, but I think technically some people would say this would be one of Michael's type 2 muscle injuries. You can't really be sure in this instance, what's going on with the muscle, so to secure it. But we don't really have evidence.
So no injection, because it might make it more difficult.
Yeah.
Perhaps you can inject afterwards to see,
you could to see, if it's submucosa, because if you put contrast in, that would stain the submucosa.
Whether you have some at the margin and
to maybe help you see if you've gotten it all.
Yes.
Exactly.
Okay.
But so anyway, here this is the simple approach to a recurrence. Now,
margin coagulation and clipping for safety.
Yes. Yeah. And neither one of those I think are really studied in this setting, but they kind of make sense. Margin coagulation seems to have
from the primary resection.
Yeah. Exactly. Okay.
That's a big one.
Yeah. Now this is a big lesion in the right colon, and we now have these 4 randomized controlled trials comparing cold EMR to hot EMR, and if you consider does cold EMR have any role anymore? I think if there's any group of lesions where you could consider it, it would be the homogeneous granular ones. I think your study nicely showed that if there's a nodule, it's probably better to not do cold EMR.
What we are going to do currently is to analyze the original data of all 4 trials. Maybe the subgrouping could be better, that we see what you could do cold.
Right. And so in this case, there are several things, and this applies again, I think, to having some sympathy for the referring physicians, but several things to consider in deciding if a homogeneous granular lateral spreading lesion could be removed cold. One of them is whether you can close it. Now, this defect, which you're going to see, is going to be quite large, and it could be closed. I think it could be closed with X-Tack and perhaps with closure clips. And so, but occasionally that's an issue. There's something that's so big, you're not sure if you can close it. Secondly, if you remove it with electrocautery, can the patient tolerate the complication? Are they elderly? Do they have comorbidities? I think in America, for the referring physician, cold is very attractive because some people don't want to have a complication in the setting that they're in. In Indianapolis, in Berlin, Hamburg, Cologne, you can have a complication and nobody knows about it. But in a small town, everybody finds out. So there's also tolerance, the doctor's tolerance, and then I think also engagement. So this particular patient, for example, was a young woman who came from out of state. She had found my name on the internet, so she's obviously very engaged. She's going to do whatever you tell her in terms of follow-up. And in fact, if we decided to do this cold, we get through the initial process without really any risk of a complication. And then when the patient comes back, the scar is always very contracted. This is the ileocecal valve, and this is the scar. And there is a recurrence. There's a small recurrence here. But now we have a much smaller lesion to deal with. And again, we have these same options that we discussed in the last case, but I typically deal with them with just the electrocautery snare. And the same issues come up about injection. I think this is enough on the scar that probably won't inject well. The other thing when you inject, when there's a lot of scar tissue around, is you're more likely to not find the submucosa right away. You get these intramucosal blebs and
you flatten it out.
Yeah, exactly. And so sometimes it's just easier to grasp it, burn it up, and
same
clip
principle
it.
as before.
Same principle, exactly. Let's go on to another one. This is one that's a little bit bigger. This was actually referred. So this is a partially resected lesion. And again, I think the doctor maybe felt that they hadn't gotten the whole thing. We're in the right colon. And you can see from the distortion here at the left edge and the way these folds are coming in that there's scar tissue underneath pretty much all of this lesion. So, and this is, I would say maybe, I'm not sure what you would think, Thomas, I would say 15, 17 millimeters in maximum dimension, not huge.
On both sides of the fold?
On both sides of the fold. I do think that this would be, here you can see again the scarring on that edge of it. And I do think, this would be a candidate for full thickness resection. But I typically, as you're going to get the theme of this, I want to talk a little bit about specific techniques for fibrosis, the CAP technique, which I use a lot. The bottom line is everybody needs their tools to deal with fibrosis.
Well,
and
if you do full thickness here, you might consider, depending on how hard it is, to trim the margins a little bit. That you have a better visibility and you're sure that you're getting it. But
yes, kind of a hybrid.
Yes,
a hybrid
that's
thing.
What people often do nowadays.
Yeah.
So here's your snare.
Right.
No injection again.
Right. Yeah. So I am going to show some that I injected later, but I do think sometimes in this setting, injection just makes it a bit harder. And I don't think that this is so big that we have to do injection. You can see it keeping a little bit deflated. And I think that some people at this stage might think that snaring right there is a little bit scary. But I, over the years, have found that generally, I mean, this is not the setting. I always think when you get a muscle injury or perforation, it's almost always when I least expect it, and when I'm worried about it, it almost never happens.
That's right. And we have much better tools, so and CO2 helps and all that.
And to deal with it, but that's really just a nice submucosal defect. Very fast.
What about here?
Yeah, there's a little bit of recurrence, and I think I actually did a bit of avulsion in that corner, and then burnt up the margin and clipped it up. So this technique, I've found to be pretty successful. And so if we have anything on the edges, of course we can re-snare it or use avulsion. If there's actual visible polyp, of course we don't want to ablate. And these pits I think are are pretty normal as we're tracking around here. I like hot avulsion myself. Greg Haber really kind of developed this technique. We've switched the current over the years from using coagulation current now to pretty much using pure cutting current. So we have this on endocut eye, and you want to grab a fair amount of tissue, not a huge amount of submucosa, and then get some mechanical tenting on it, and then tap the endocut eye, and we just have it on almost pure cutting current, so on the 1:1 setting. And but this is a safe way actually to deal with a tiny area of flat polyp. Sometimes in serrated recurrences, they'll be very small, just a few pits, and right on top of a scar, and very flat. And under those circumstances, I may choose hot avulsion as the primary form of treatment. So after we've taken everything off that looks like visible polyp, either with snare or by avulsion, then we're doing our snare tip soft coagulation treatment, and then we'll close this, with clips, and that'll be the end of it.
Margin ablation makes clipping more difficult? No.
I don't think it really does. In my experience, I don't think it does. And I think with the tools we have with clips now, we can close almost everything that we want to. So let's show this case finally. This is a rectal lesion that the referring doctor had treated 9 times. Now, Thomas, that actually is a record for me. We do see cases that have been treated 2 or more times, and I usually think people, if they go back and they have a couple of recurrences, they probably should give up and let somebody else have a crack at it. But this is in the rectum, and I think that when I'm watching live courses, talking to people, this is a lesion that's often undertaken by ESD
or even deeper.
yeah, exactly. Yes, intermuscular dissection. And again, I think the approach here that I tend to take is mostly has to do with just the convenience of the tools, the standard tools, and the safety of them. So in our experience, we had a perforation rate using these standard tools on 220 recurrences of less than 1%. Whereas the perforation rate, if you do ESD, is probably going to be at least 4% or 5%. And I think especially for people early in their experience when they're dealing with fibrosis in the proximal colon by ESD, the perforation rate can become pretty significant. This is the cap technique. So use a fairly small snare, put it around the tissue that is the target, and then approach very closely and suction the tissue up into the distal attachment, this short cap or hood on the end of the scope. And then the technician closes the snare blindly and just by feel, and then you release the suction and then take a look. So
now it gets tricky in the middle, huh?
Yeah, exactly. It's very fibrotic in the middle. And
suck, be patient.
Yeah, so exactly, suck, let it come up. The beauty of this technique from a safety standpoint is that this cap is only sticking out a few millimeters. And so you're very unlikely to get, I think I must have given up there. And now we're switching for the middle part. But you can see that I did inject this, and I think many times, injection is appropriate. Part of it probably not very fibrotic. And many times, even if it doesn't lift with injection, you'll get some staining of the submucosal plane. And here is avulsion to clean this up. So again, cold avulsion, the cast technique, people will pull the tissue off with the cold forceps and then go back over it with the snare tip. I think one advantage of hot avulsion, we don't have a comparative study between hot and cold avulsion, but is that the defect tends to stay very clean. There's just very little bleeding, and
which is very important because visibility is the key.
Yeah, it's very nice. And then in this case, I used APC. Now we would probably use the snare tip on soft coag, burn up the margin. And then we just leave the defect open because we're down here in the rectum. And this actually would be, I think, hard to close with standard hemostatic clips just because of the amount of fibrosis.
Yeah, you would have to suture, do some crazy stuff.
Yeah. I have seen this patient in follow-up a long time ago. This was an effective treatment. I kind of like it because these tools, the cap technique and avulsion, are available to all of us, whereas the use of ESD, the full thickness resection device, more select group of endoscopists. But certainly at this point, all of these lesions should be coming to somebody who's an expert in resection.
No, absolutely. And if you really want to find out, because the recurrence rate is not so high, whether ESD is better or the conventional technique, it would require a randomized trial.
Right.
And for the full thickness, as I said, it'll come. So we will learn more.
Right.
Yeah.
I certainly in the rectum, because this lesion had been worked on 9 times, and I didn't see anything on the surface. I didn't really have any concern that there was cancer, but I would agree that ESD would be the right approach in the rectum, or even intramuscular dissection if there was an important concern about cancer.
Well, if I look back to the live demos I have in mind, there were a lot of ESDs, and histology was mostly low grade. So it's
yes.
Although the justification was always there could be something, but that's a discussion we don't go into now.
Exactly.
Okay, Doug, thanks very much for this enlightening session, and we'll be back soon. Thanks very much.
It's been fun. Thanks, Thomas.